everybody to our show today. My name is Dr. Arinola Dada. Welcome to the Healthy Joints, Healthy Lifestyle Show. I am so excited to introduce to you Dr. Erica Bove. She is a double board certified OB-GYN and reproductive endocrinologist at the University of Vermont. So we are so honored to have her here. I am not even going to attempt. I am going to let Dr. Bove introduce herself. So she is so accomplished. We have a lot to talk about on our show today. Welcome.
Thank you, Dr. Dada. It's so wonderful to be here. And so, like you said, I'm faculty at the University of Vermont. How I spend my days when I'm working clinically is helping patients build their families, whether that's through optimizing natural fertility or helping people with some technology, and also really the endocrinology side of reproduction, which is, menopause, puberty, like all the things that sometimes we don't think about when we think about, the full spectrum of reproductive endocrinology. I'm also the fellowship program director there. So I'm very passionate about training the next generation. But I will also say that as I was, getting into my attendinghood, I was feeling more and more disillusioned about how I was actually able to help people. And I just saw this huge gap in these brilliant, successful, healthy young women who were not getting pregnant with fertility treatments, right? And I started to ask the question, okay, what is going on? How can I connect with them? How can I help them make better choices? Because it just this analysis paralysis was going on. And that's when I decided to found my fertility coaching practice, which is truly my passion. It's called Love and Science, Thriving Through Infertility, where I help female professionals to build their families, not just by themselves, because we don't heal in community, but together in community with one-on-one coaching, group coaching, and all the coaching tools to help people ultimately bridge to becoming parents.
Fantastic.
Yeah.
So, you kind of mentioned it a little bit about kind of, why you do what you do.
Yeah.
Can we start from like the inspiration? I think it sounds like you were already kind of in that track and you're like, hey, there's a whole segment of people that I'm not really getting to. Tell
Yes.
us a little bit more.
Sure. So I like to start by saying I went to med school to be a psychiatrist. I think that's relevant because I've always been so curious about what motivates people, what helps people make good choices. I'm sure I know I've listened to your podcast, like similar bent towards helping people live their best lives, right? And so as I was, really getting into practice and taking care of patients every day, I just felt like this disconnect. And, my own friends were my patients, right? Small community, right? My friends, my colleagues, everybody seemed to be suffering in silence. And it was almost the rare occasion when a patient of mine actually had a positive pregnancy test. And I was like, I'm spending my days giving bad news, helping people assimilate the negative pregnancy test, help them figure out if they want to bump it up on the technology. And this is like everyone says, fertility specialists, oh, your job must be so happy. Well, it is when it works, but it felt like it was working like only a small fraction of the time. And so so I started to recognize patterns. It seemed to be that the people who were most in their heads about these things and the people who were least trustful or most disbelieving that it was going to work. I would say the most defeated, the most hopeless to begin with, those were the people for whom I just knew in my soul it wasn't going to work. I will tell you, I even had a patient when I was about to do her embryo transfer say, Dr. Bove, I'm telling you this transfer is going to work. And I was like, whoa, 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 whoa. If you're telling me it's not going to work, it's not going to work. So let's just like do whatever we got to do. Let's clear the negativity. Let's do some breathing. Let's do some praying, like whatever it is to help you believe it's possible. Yeah. And I found time and time again that when we could reconnect the mind and the body, when we can help people remember their deepest why, when we can help people trust their doctors, trust the process, be confident in their plans, that's really when we see the science start to work. And so, I was just amazed that my patients were doing so much better as I was introducing these concepts. And so that's why I decided, because I thought, people deserve this. People don't deserve to be doing cycle after cycle after cycle with only bad news. They deserve to become parents. That's what they're here for. And so how can we do that in a better way? And so that's really why I founded Love and Science, was to be able to do that holistically.
That's fantastic because there is such a need. We have a lot of professional women, not just physicians, who have somewhat delayed nobody's getting married at the time Mary did anymore, right? So women are delaying that for professional reasons, and I'm even finding in my practice, women who have lupus, autoimmune diseases, who are kind of struggling with fertility. So I think this is definitely going to be a very well listened to program. So yes. Okay, so are there any we kind of segued into into what I was thinking of for the next question is, are there any autoimmune or rheumatologic issues that you commonly see? Because that's my world, is autoimmune, rheumatology. Are there any that you commonly see? Fertility or increase, or
Yep.
people have an increased chance. I know about lupus, but tell me your world from because you have kind of more that huge view of infertility. What
Sure.
autoimmune rheumatologic issues do you commonly see?
Absolutely. So there's a lot. And I will tell you, there is a huge connection between rheumatological diseases and infertility. It's always a question of the chicken or the egg. But what I will tell you is whenever I see a patient who comes in with a diagnosis of a rheumatological condition or autoimmune condition, I start to worry about their fertility. There's something about having a rheumatological diagnosis which makes it harder to get pregnant and stay pregnant. Sometimes we see people are getting pregnant, but they're not staying pregnant. And so the question is, what do we do about that? Right. So I will tell you, there is this newer emergence of literature that early ovarian failure, which means that like in the 20s and the 30s, the ovaries act like they're in menopause. We think that a large amount of that is actually due to autoimmunity. So antibodies to the ovaries themselves that are slowly destroying the ovarian gland. And so that's a huge area of research right now, is to figure out how to do that. But when I see that somebody has lupus or RA or ankylosing spondylitis or all these other conditions, and maybe their families, autoimmunity, they maybe have more than one autoimmune condition, rheumatological condition, maybe they have a strong family history. I start to wonder, I wonder if part of their story is that they have these antibodies, which we're really poor at measuring these days, but you
Yeah.
you kind of know that they're there. It's not normal to have an FSH of 28 when you're 25 years old, right? So you start to put together the picture. And I really do think that that's going to be an area, for not just research, but therapeutic intervention in the next few years of being able to forestall this and possibly even block it. That would be so wonderful. So, there's certainly that connection that by association that there's probably anti-ovarian antibodies floating around that destroy the ovaries. Also, we don't exactly know the mechanism why women have higher rates of recurrent pregnancy loss. It probably is related to something with inflammation, because we know that when people get pregnant who do have these diseases, the best prognostic factor is actually kind of the stage of the disease, the control of the disease when people do conceive. So if somebody has like a raging flare, I always say talk with your rheumatologist, like get that as well controlled as possible. And then, we'll do what we can in terms of the pregnancy piece. And then, then there's the medications. I think it's really tricky because there are many medications we have data for, but there's many of, especially of the newer biological agents, we just don't have a ton of data. We have some data, but not everything. So it's always a balance of, if you need to be on one of these medications to control your condition, then, what do we do and what are the guidelines? And that's where I think a multidisciplinary team really comes into play.
Yeah, I totally agree. And we do tell our patients that, hey, you're planning pregnancy. We don't like surprise pregnancies in rheumatology. Everything gets to be planned. And yeah, from the time they walk in, we're saying, hey, if you're pregnant, are you thinking about pregnancy in the next few years? And then we're going to tailor your treatment to make sure that you'll be able to, one, get the disease under control and also be able to conceive safely. And yeah, we always want to get that autoimmune disease, exactly like you said, under control before conception. And so have
Yeah.
things be stable. Interestingly, we find that a lot of autoimmune diseases also tend to get somewhat better during pregnancy.
Mm-hmm.
But once that cortisol level drops, once that baby comes out, then we I tell my patients, then we get to treat you like full on, right?
Mm-hmm.
But sometimes it's because of the medications, we have to be cautious what's safe for the baby, what's safe for the mother during pregnancy. And but exactly what you said, we work hand in hand with our gynecology OB-GYN colleagues in high risk OB clinics to make sure that we have the best outcomes. And you're right, we don't really have a whole lot of medication available for us, but we have some tricks up our sleeves for sure.
That's true. That's true. And I also think there may be a role for fertility preservation, and we are talking more and more about this. It used to be just for cancer patients, but I think we know that a lot of the medications used in rheumatology, methotrexate, et cetera, can have, a really impairment on the ovaries over time. And so if there is an appropriate window and you know that fertility is important to you, especially given that people who do have rheumatological diseases often will have lower egg reserve than their age-matched counterparts, even if they've not even received any medications. There may be a role for freezing eggs on the earlier side so that when you are ready to conceive, it's not an insurance policy, but at least you have younger eggs ready to go in case you do have a hard time. And also, I will say that at our peak fertility, we conceive at about 20% per month. And that's, when we're young and fertile. As we get older, especially mid to late 30s is when it starts to set in, we get less efficient. So sometimes like, okay, go off your meds and try, we don't want people off their meds for too long. So sometimes in vitro fertilization, even though it's more to go through, can be a more efficient way to get pregnant, obviously in select patients, but I think it should be part of the conversation.
Definitely, definitely. Yeah, there are definitely some medications, like, especially it's just hard, sometimes because the patient's already so sick by the time you're making those decisions. So it's hard to say, let's take some time to go do some, harvesting.
Yep,
So sometimes it's a tightrope to walk. But again, that's why we have multidisciplinary teams to help
that's
you
right.
make sure that we get the patient to kind of the outcomes that they want safely.
That's
Okay,
right.
so, if someone has had multiple miscarriages or even unexplained fertility, when should they consider being checked for an autoimmune disease? That kind of part of what you do on day one. How does a patient navigate this?
That is such a great question. So if you don't already have a diagnosis and you present on the fertility side, what do you do? So, it's interesting you mentioned unexplained infertility. There is a huge crossover between unexplained infertility, which means that we've done all the typical fertility tests, sperm test, tube test, ovarian reserve markers, the whole thing. Everything is checking out, but people aren't getting pregnant. If you actually look at how many people who have unexplained infertility also end up having endometriosis that really is only best diagnosed on surgery, there's a huge overlap. And there's also a thought that endometriosis may be autoimmune. So that's why I bring that into the picture, that I think that, these are all so related. And so what I would say, unexplained infertility, that's really it's diagnosis of exclusion. I think that it's I'm more likely to search for a rheumatological disease in somebody who has had recurrent losses. If you look at what the data tells us, and I also believe sometimes we need to expand this to be inclusive to help people the most. If you look at what the data says, they recommend screening for antiphospholipid antibodies. If somebody has, well, different definitions. The European Society says 2 consecutive losses. Our American Society of Reproductive Medicine says 3 consecutive losses. When people see me and they've had 2 losses in a row, they are anxious, they're stressed, they're sad. And so I'm like, why do I wait until somebody has a 3rd loss to, diagnose something where there's possibly an intervention? So I usually say 2, and then we do the evaluation. So, that's pretty straightforward screening. You just need to wait
Yeah.
till somebody's beta HCG is negative, because that can cause a false positive with the testing. And then we get those tests. And then, as if those are positive, we repeat in 12 weeks. And then if somebody truly does have antiphospholipid antibody syndrome, then we can give baby aspirin and Lovenox. And then I think the larger sort of panel for rheumatological diseases, it gets really tricky. I think antithyroid antibodies, we do screen for those because we know there's such a high association between thyroid autoimmunity and recurrent pregnancy loss, and that even the presence of thyroid antibodies alone does increase the risk for miscarriage. The hard part is, what do you do about it, right? Good thyroid control is important. So making sure that the titration is good with the thyroid replacement. But also, people have looked at steroids, and steroids don't really seem to make that much of a difference, at least from the data that we've seen. So that's a tricky one, because we know there's an association, but there's not a ton that we can do about it other than, good thyroid control. And then if somebody's ovarian reserve seems to be kind of lower than we would expect, so like more severe diminished ovarian reserve for somebody at younger ages, that's also when I would really consider looking for, autoimmunity, because there's such a strong association there.
When you say auto ovarian reserve, how do you determine this?
Yes. So there's three different parameters we look at. The first one is a blood test. It's called the anti-Mullerian hormone. I gave my grand rounds on that as a second year resident. Nobody had heard of it, so I'm dating myself. But now we pretty much check on every single person. It is not a fertility test. I want to be clear about that. But what it shows is kind of if somebody's say somebody's like 30 years old, I say, are you on the good side of the numbers in terms of egg number for your age? Are you on the bad side of the numbers? You have very few eggs for your age. And then that corresponds with a response to medication. So if I take somebody through an IVF cycle and they have a very low AMH, I might only get 2 or 3 eggs. Whereas if somebody has like a robust egg reserve, a very generous supply, high AMH, then I might be able to get even into the double digits, 10, 15, 20 eggs. And so that's that AMH value. So obviously, if you're 40 years old, it's going to be different than if you're 25 years old, but it's a nice marker that we can look at in terms of like, how's your egg number? Is it average for your age, which average is actually good in our world? Is it high? Is it low? What kind of doses might we need to give you to get your ovaries to respond to medication? So that's the first thing. The second thing is also blood work. This time it needs to be timed to the menstrual cycle. So we get the follicle stimulating hormone and the estrogen. Those two need to be checked together because they affect each other. And
Yeah.
typically we get them on cycle day 2, 3, or 4 of the menstrual cycle. And so we want
Okay.
the estrogen to be under 50 to be able to interpret it. And then the FSH, we like to be under 10. So we can look at those two things. If the FSH is above 10, when the estrogen is low, it means that the brain is working too hard to keep the cycles going and the ovaries are starting to suffer. So the brain's starting to like yell at the ovaries. And that's why you have the elevated FSH. So that's the second parameter. And then the third parameter is actually ultrasound, where we do a scan through the ovaries and we see how many follicles does somebody go through in a given month? The follicle is the functional unit of the ovary. So, in a given month, eggs are social, right? They like to be surrounded by other eggs. They actually support each other in so many ways. And so if somebody has a group egg size of 15 to 20 in a month, I know that's very healthy. The eggs are doing what they're supposed to do. But as we get older and as our egg number gets lower, because unlike men who make sperm all the time, we're born with all the eggs we'll ever have. And so over time, once our body notices that our egg number in our body is lower, it conserves. So say when I was 25, I went through, 30 eggs every month, but then I hit 36 and now I'm going through 12 eggs every month. It's conserving. And so that number not only tells me response to medications and how many eggs I might get in an IVF cycle, but it also tells me kind of how's the body doing compared to, age match controls, and is somebody on the good side of the numbers or not so much. So if I see a 28-year-old and their antral follicle count is 6, I'm going to say, oh my goodness, like that person really has low egg reserve. What can we do about this? That's somebody I might say, you might really want to think about freezing your eggs because I don't know how quickly this is going to happen, but you're definitely on like the tail of the bell-shaped curve for somebody in your age range, if that makes sense.
Interesting. Yeah, that is actually very interesting because yeah, so I'm just going to recap just because that was a lot of information, very packed. So, but I think, so my question was basically, how do we know where you are kind of in your basically the lifespan of those eggs? Because unlike men who have sperms that are continuously being produced all the time, we're born with a number and then it starts to diminish over time. So we talked about the anti-malarial hormone antibody. We talked about the FSH estrogen, that's number 2. And then basically, if your FSH is high, it means that your brain is trying to whoop your ovaries into shape, right? Otherwise, and you have to check your FSH and estrogen at the same time because they're very correlated with each other. And then finally, the ultrasound, because those eggs kind of, they like to party together. So once you have one egg, there's usually about 15, 20, where like life is good. If you're 26 and you kind of have a number like 6, we're like, hey, maybe it's time to think about conserving some eggs. I think this is really very helpful because a lot of professional women, are kind of thinking about this as a delay. It'd be nice for them to actually know this and
Yeah.
then and then act on it, and then they can say, hey, you know what, my reserve is very low, maybe I should have a conversation with someone like Dr. Bove, or
Yeah.
hey, I'm looking rich. My
That's right.
egg supply is looking. That's right. Actually,
That's
I did
right.
not know this.
And there's quality and there's quantity. So AMH, the anti-Mullerian hormone, is a quantitative test. So if that number is less than 1, and I'm talking in American units, Canadian units are different, but if that number is less than 1, then that's a time I'd be worried that somebody has low egg reserve, right? But if somebody's 38 and they haven't met their partner yet and they're really starting to worry, then I might say, you know what, even though you have good egg reserve, you're 38, your quality is starting to go down. Now might be a good time. So it's that balance between quality and quantity.
Yeah.
And that's, why it's so important is if you are interested in fertility, see a fertility specialist. They can get some testing, they can look at your goals and plan, just as we plan in so many other aspects of our life, just to even like state our desires, have somewhat of a roadmap. I think it can make a big difference.
Yeah, that's amazing. Thank you for that.
Yeah.
So, what treatments or approaches can help patients with autoimmune issues improve their chances of a healthy pregnancy?
Mm, that is such a great question. So I think the first one is to make sure that the disease process itself is in the best shape possible when somebody is trying to conceive. I think people have talked about these like anti-inflammatory diets, and it's a very loaded term because it is kind of assumes a one size fits all approach, and that we know that's not how humans are. But I will say, gluten sensitivity can be more common in people with other autoimmune diseases. And so if that's something that affects you, or maybe you even have full-blown celiac disease, there are some data that avoiding gluten can really, affect your outcomes in a positive direction. So there's that. Same thing with dairy. Some people are sensitive to dairy, and for many people, dairy is just fine. But for other people, it's not. It's not. So if you're sensitive to dairy, then avoid it. Other dietary concerns. I mean, there is a lot with lifestyle. I mean, truly, I think that, we talk about eating whole foods and how important it is to eat from the outside of the grocery store instead of the middle where all the processed foods are, because those processed foods are not good for our microbiome. They're not good for our insulin, status. And so really trying to eat as much whole food as possible. And also, if you are a person who happens to smoke cigarettes, or maybe you have secondhand smoke, or maybe your partner is smoking,
Yeah.
those things are not good for the reproductive tissues. And so, if I'm a 38-year-old woman and I smoke a pack of cigarettes a day, even half a pack a day, that's going to add 5 years to my reproductive life. And so, I mean, being 43 is a lot different than 38. And so just being very mindful that the things that we put in our body are especially important for people with autoimmune diseases, because it's like a double hit. If you already have the hit with egg number, and then you add cigarette smoke and toxins on top of that, that can be really, really difficult. I think having a really excellent rheumatologist is a really, really important factor. I know, a lot of people, you kind of got to be up on like the data, on the meds, the newest research, so, if you don't have somebody like Dr. Dada in your corner, go get her or somebody who's an excellent rheumatologist, because I think that relationship is so important. There's a lot of unanswered questions. There's a lot of need for conversations with other doctors. It's a very complex conversation. And I think, we all know when we're not getting the best care, and we do know when we're getting great care, and you deserve great care. And so having somebody who really can think about you and your particular situation and weigh the pros and the cons, and talk these things through with you and your family, I think that's probably one of the best things you can do.
Yeah, I totally agree. I totally agree with that. And just making sure you have a good multidisciplinary team, just make sure that you get the best options, because these are important decisions that you're making at this point. And it's so interesting how, we forget secondhand smoke. And if you already have an autoimmune disease, I tell my patients sometimes, because I'm dramatic. I'm like, it's Russian roulette. You already have it loaded. You already have antiphospholipid antibodies. Then you're smoking. Then you're rolling the dice, right?
That's so true.
Yeah, and even secondhand smoke. So a lot of times people forget, but if they're kind of in an environment, let's say they're a waitress, for instance. I mean, we hardly smoke indoors in the United States, but outside the United States, it's everybody's just puffing away, and I'm like always shocked. But yeah, so even secondhand smoke, you kind of have to be aware that that could be kind of like the second trigger, and that could impact your ability to have good, just healthy fertility.
Yeah. And I will say there's also, a body of literature. The data are not strong, but I have seen some people for whom this has made a difference, is the sort of the notion of like, a baby aspirin plus minus Lovenox, and I think it's you got to be really careful because sometimes these medications can come with risk as well. But there's some people who you do every single test and they have a rheumatological disease or autoimmune disease, and these are beautiful embryos, they're completely chromosomally normal and everything's aligned, and then 6-7 weeks comes and people just have miscarriage after miscarriage. Sometimes you do need to get the blood to flow better. And it's obviously a conversation because if you hit your head on your cabinet or you get into a minor car accident, so that can be much more serious. But, I think it's a conversation with, your OB-GYN, maybe your fertility specialist, your high risk OB doctor and your rheumatologist and you to say, okay, like what are the pros and the cons? Because I do give these medications even in the absence of antiphospholipid antibodies because I do think they can make a difference for some people, not everybody, but it ends up being a risk benefit calculation. What do you think about that, Dr. Dada?
I totally agree. We do that too, actually. We're like, yeah, we don't have all the evidence, but we do think that the benefits outweigh the risk. So definitely you want to talk to your doctor about that. But I think it's pretty benign. And we've just had patients that are like, so what did they do? What happened during this pregnancy? Like, I was told to take a baby aspirin and I did, and here's a bouncing baby, right? And so, yeah, so, sometimes we just don't know. We haven't discovered all these antibodies, but we do know that some things work. And with each patient, we look at the risks and benefits. And I totally agree with you. In that situation, the benefits totally would outweigh the risk. But again, it's on a case-by-case basis. So I think that's something I think we both definitely agree on. Yeah. So how do you think fertility coaching kind of leads to better clinical outcomes for patients with infertility? Tell me about this.
So many ways. So I will say, gosh, I mean, I'm obsessed with group coaching as well. And I know that's not everybody's thing, but I think that one of the hardest parts about the fertility journey is it's so incredibly isolating and people are truly suffering in silence and feel like nobody else is going through what they're going through. Nobody else understands. And so when you can bring beautiful, smart, educated people together and say, oh my gosh, I'm not the only one who thinks that. Oh, I'm not the only one who's worried about that. And then people start to rise together. There's something so very powerful. And maybe it's not even through coaching. Maybe it's a local support group that you can find. I've had, patients of mine who discovered that they, in the same cubicle, that they all were my patients and they started a lunch group. Like, we need to break out of the isolation because we heal in community. We help each other in community. So that's the first thing. And I think, one of the premises of coaching is that we all carry around what I call these limiting beliefs. Right? Limiting beliefs. I can't do it for this reason. It's not going to work because I've only gotten negative news. I'm actually going to be a terrible mother. And so this is the universe or God punishing me and I don't deserve to be a parent. I mean, I seriously hear it all. But I think if that's our core belief that we don't deserve to be a parent, then we're going to act in those ways. We're going to, by accident, mess up the medications. We're going to self-sabotage. We might even drop out of treatment because the mental load, maybe it's driving a wedge between ourselves and our spouse. I mean, there's so many ways that this affects the entire life of a person. And so what we do in coaching is, first of all, we calm the nervous system, right? When people come to find me, they are so distraught, they are so devastated, and they're not registering any information at this point. The anxiety, the hypervigilance, the sadness, the fear, it's just paralyzing. So first we got to work through the feelings and kind of metabolize those. And then once we are through that, then we start to think about, okay, who are you at your core? Who do you love? What other hard situations have you gotten through and demonstrated how incredibly strong you are? How can we borrow upon that version of yourself for the version of yourself today who's facing this big mountain? What are your values? What is your identity? How many children do you want? I will help somebody in a much different way if they want one child versus if they tell me they want 5 or 6 or 7 children. So we meet people where they are, but we have to really focus on the individual and who they are and what they're hoping for, because that then becomes so crucial. So then we say, okay, well, what are your factors for authentic hope? Authentic hope is not just this pie in the sky hope. Authentic hope is hope grounded in science. And I see a lot of it when I listen to your podcast, Dr. Dada. I think we're very aligned in this way. So we have to say, okay, what are your good factors? Why am I excited to take care of you? And why do I think this process is more likely to be successful than not? What can we hang our hat on that's actually in your favor? Because our brains, they just ignore all that stuff, right? So that's the next thing, is we identify those factors for authentic hope. And then the next part is really then getting into the coaching. It's, learning what our triggers are and how we can prevent them and handle them in real time, learning how to set boundaries. Maybe we haven't been setting these all along. How can we fill our well? How can we have self-compassion? How can we, have better relationships and talk with the people who we care about what's really going on with us? And so I think there's a multi-layered approach, but what coaching really does is it helps us get back in touch with who we are and find the answers within ourselves with a guide so that we can make empowered choices, so we can trust the process, and so ultimately we can have a successful outcome.
Yeah. Yeah. I think that is so I'm taking notes here. This is so, I mean, this is just so on point. We don't need another hero. We need a guide that's going to help us kind of figure out what we want, right? To help us get the results that we need to get. This is so important. I'm going to have to tell my patients that are kind of going through this phase to really come and listen to you. Can you share a story of a patient who's had an amazing outcome after the benefit of being in your program, I'm
Yeah.
going to say? Yeah.
Absolutely. So I have one client and I adore her. We've been working together for quite some time, and she and her husband were doing IVF and it just wasn't working for them. They had all the testing of the embryos, all the, everything, and it wasn't working. Either she'd get a non-pregnancy after an embryo transfer, or the embryo would stick around briefly and then, go away. She'd have a miscarriage. And so I remember, like, she was like holding on to this notion that she was broken. She was like, you
Mm,
know what? Like, I'm the
yeah.
problem. It's my fault. My body is
Mm,
faulty.
mm,
And this
mm,
is this is the universe maybe saying, we're not supposed to have
mhm,
kids. So we
mhm,
work together, work together, work together. And part of what I do is I help people surrender, I guess is the way to say it. And I help people see that we want something so deeply. And sometimes when we want something so deeply, we are so attached to the outcome. And by that attachment, we like squish, squash, strangle the outcome that we're hoping for, right? And so, what I help people do is I help people realize that even if that desired outcome does not happen, they're going to be okay. They're going to have great relationships. They're going to have a meaningful life. And so, how can we loosen the grip on that outcome to allow God, the universe, whatever you want to call it, that life force to really flow through us?
mhm.
And so I remember I was working with this client, and all of a sudden she was like, you know what? Like, I think it's going to be okay if we don't have children. Like, I want this very deeply. But you know what? I'm going to trust in the plan for my life. And so, so instead of doing IVF 1 month before she was about to go to Europe and honor her ancestors with her family, she was like, I think we're just gonna like try on our own this month. We're just gonna see what happens. And it was the most amazing thing because she didn't check her ovulation predictor kits. Sometimes that can become like a control thing. She didn't even check a pregnancy test until she really wasn't getting a period. And it was so amazing to me because this is a person who needed IVF, had had several egg retrievals, maybe like 5 or 6, had had several embryos transferred. She was so stressed, it wasn't taking. And then all of a sudden, when she surrendered, when she let go of the outcome, she understood it was going to be okay no matter what. That's when that little embryo came. She got pregnant. She stayed pregnant. She's had normal first trimester screening. And, it's just so beautiful because I think that is like, you hear these stories of like, oh, if once people finally consider adoption, then they also conceive.
Yes, I was,
It's that same sort of
yeah,
surrender.
yeah,
And so,
yeah.
and I can tell you
Surrender.
stories of
Yeah,
people with autoimmune diseases where
yeah,
this has been the case as well, but
yeah.
it's really helping people reconnect their minds and their bodies and hoping for the outcome and
Yeah.
then letting go of the how,
Letting
letting
go.
go of the process,
Yeah,
and
letting go of
leaving
the
room
process.
for that which is greater than ourselves. And that's when we really start. I can almost tell when it's going to happen when I'm on the call with these
Yeah,
people, because you can see the energy shift. And
yeah,
so that's why I say it's love and science, right? We need the science, that's foundational.
yes.
But unless we can align ourselves with our highest good, with the surrender with each other who's going through this process, that's really when the magic happens. And so I see stories like this every single day, every single day. I have a patient or client, excuse me, in this context, a client a couple of weeks ago who saw her first pregnancy test after 20 years. 20 years. And I'm like,
Wow.
I witness miracles every single day. But it's because, you asked, how does the coaching help? I think we are so stressed out all the time. When I look at, you know, our colleagues, ourselves, sometimes our calendars are booked. We're racing from place to place. We're shoving food in between, meetings. And it's like, this is no way to live. And so I think when we can be more intentional, when we can slow down, when we can make these choices for ourselves, that's really when we start to engage that mindfulness, reconnect the dots, reconnect our minds and our bodies, and really start to see the miracles.
Yeah, yeah. That is so, it is, I was gonna give the example. I think everybody knows that example of just somebody who's gonna adopt, or sometimes they adopt a child and they're like forgotten all about, and poops, what happened? They were pregnant, boom, boom, boom. And so that's such a strong idea, which is that you help people see that even when they love something and they want something so deeply that they start to suffocate it, and then they just have to kind of let go and just let the universe like do its thing. So wow, that is so strong, and there's so many examples of that, right? When we want
Yes.
something just so much, and we are clocked in, measuring everything. Wow, that is so. Thank you for that story. It's just so heartwarming.
Yeah, we
Just
need to
what?
try less. We need to,
Yeah,
like, we're not trying harder. We're
yeah,
doing less, which is, it's
yeah,
hard for us, especially those who are hard workers. And
yeah.
especially when in every other aspect of life, that's always been the equation. So
Yeah,
it's almost like an
you
unlearning.
control.
Yeah.
Control. Yeah, yeah.
Yeah, we have to let go of control. And I know, I promise you, especially when you love your fertility doctor, especially when you
Yeah,
have a guide, like a coach, a
yeah.
rheumatologist like you who can help to make these, help make these hard decisions, help people guide people through, that's really when I think people can disarm themselves of their hypervigilance. They can trust the process. They can be confident in the plan because people have their back.
Disarm yourself from hypervigilance.
Yeah.
I love that story. Thank you for sharing that.
You're welcome.
So, you already have so many superpowers. I don't even know I should even bother with this one. But I always like to ask, just in case, if you had any superpower, what would it be and why?
Oh gosh. I mean, the first thing that came to my mind is flying because
I
I'm a
think about it.
person, I love freedom. I love freedom. And, the couple of times I've gone like parasailing or bungee jumping or anything like that, even though it's kind of scary, like I love that feeling of just like gliding through the air
Being
and being free.
airborne.
And I also think like that sensory feeling would be amazing, but I also think it would give such a perspective. Like I love, some people hate to fly. I love to fly because I love how I can see the earth in a different way. And so I imagine the birds get to see this all the time, the geese. And so I think if I could have that sort of higher view of everything, I think that would be very, very exciting.
Oh my gosh, I love this. You are phenomenal. I'm going to have you back. You are just
Oh,
amazing. Thank you so much for sharing on this very important topic that a lot of our young ladies are either thinking about privately, like you said, but you're giving people the opportunity to come, share, and understand that they're not the only ones, and let go and let science and let the universe kind of, give them what their dreams are. Well,
yes.
so if people want to find you, how do they do this?
Absolutely. So my website is the most comprehensive place. It's loveandsciencefertility.com. And then I'm on social media. So you can follow me on Instagram or Facebook at Love and Science Fertility. And I also have a podcast with the same name. So come find me, and I would love to share my content with you and also see if any of my services might serve you at this point.
Oh, thank you so very much, Dr. Bove. I really enjoyed this. I'm going to make sure that we have our patients listen and watch this. And yeah,
Thank you,
so
Dr. Dada.
everybody, if you like this video, please share it, subscribe to the channel, and yeah, share it with anybody that you feel is kind of contemplating this in our lives, because Dr. Erica Bove is phenomenal, and she really brings a unique and very critical piece to make sure that you can actually get those dreams to come true. Thank you, everybody. See you next time.
Thank you, Dr. Dada.